Cualquier duda nos pueden llamar a este teléfono. Okay.
Good afternoon, everyone. This is Carol Johnson, co-chair of the APHL NewSTEPs Short-Term Follow-Up Work Group. We'd like to welcome you to our October webinar on emergency preparedness for newborn screening programs. We'll go ahead and get started with our first speaker, which is Kate Taft. Kate Taft has her MPH and over a decade of experience working on issues that affect children's health, such as early childhood development, healthy weight, mental health, and injury prevention at the public health and individual levels. As the Associate Director for Child and Adolescent Health at the Association of Maternal and Child Health Programs, she leads and supports the development, implementation, and evaluation of program activities related to child and adolescent health, including children and youth with special health care needs. This includes AMCHP's projects related to newborn screening. She has an MPH with a concentration in maternal and child health from the George Washington University and a BA in psychology from the College of William and Mary. Thank you, Kate, for joining us today, and please feel free to go ahead with your presentation when you are ready.
Great. Thank you very much for having me, and thank you all for the opportunity to present to you today. I know the topic is emergency preparedness for newborn screening programs, so I wanted to take a few minutes to share with you a resource and framework at the national level, which is the National Newborn Screening Contingency Plan. And I know many of you on this webinar are well aware of the breadth and benefits of newborn screening, and certainly how it's critical to receive timely screening. So just in general, contingency planning for an emergency helps to ensure the availability of critical resources, the continuity of operation, and it sets standards for entities participating in the activation of a plan, and adhering to established standards and maintaining the continuity of testing and follow-up are certainly critical in the screening, diagnosis, referral, and treatment of disorders identified through newborn screening, especially during a public health emergency. So I just wanted to share a little bit of background and timeline for how this National Contingency Plan framework came about and just where it is now. Certainly effective implementation of newborn screening has had a significant place in the public health arena for decades, and around 2004, APHL's established a subcommittee of its Newborn Screening and Genetics and Public Health Committee that developed a framework for public health labs to prepare for and respond to disasters or public health emergencies. In 2005, Hurricanes Katrina and Rita really destroyed Louisiana's State Public Health Laboratory and their ability to perform newborn screening. And that was deemed a really high priority, or the #1 priority, by the Louisiana Public Health Laboratory chief at the time. And fortunately, they were able to work with Iowa's newborn screening lab to ensure that screening was able to continue for Louisiana's newborns. And this was facilitated by the EMAC, or the Emergency Management Assistance Compact, and I know you'll hear more about that today. But I think that kind of really highlighted the need for contingency planning and emergency preparedness for newborn screening, and kind of initiated some regional level efforts to create emergency preparedness plans for newborn screening. The Newborn Screening Saves Lives Act of 2008 actually directed the CDC, along with HRSA and other state agencies, to develop a national newborn screening contingency plan. And this is a plan that could be used by state or region or a consortia of state in the event of a public health emergency or really any interruption of services. And so they held a workshop and used objective-based planning process to develop this national plan. The original version was published in 2010, and then actually in 2014 with the reauthorization of the Newborn Screening Saves Lives Act, there was language added that the con plan should be updated every 5 years. And so in 2015-16, there was a process to revise and update the plan, and the most recent, or version 2, was then released in 2017. So we'll talk a little bit about that in a moment. So the purpose of this con plan is to provide a framework to facilitate collaboration among federal agencies, state, local, territorial, tribal, and regional efforts to screen newborns for identified conditions during a public health emergency, and it focuses on areas for which the state public health agency assumes an oversight and role. So that's just kind of the framing for the current plan as it is, and which is the second version, as I had mentioned. In 2015, AMCHP partnered with the CDC, HRSA, APHL, and many expert stakeholders to update the newborn screening con plan. And this was thinking back on just experiences and lessons learned since 2010 when the original plan was released, and looking at ways particularly to address gaps in follow-up, and also add point-of-care screenings, which were not included in the original plan, and there was also a stronger emphasis on family engagement. And I do want to acknowledge that this was supported through funding from the March of Dimes. And this is all done with the work of amazing advisory committee members, state representatives, experts, and federal and national partners and staff. I know the text is very small and there are a lot of names, but just wanted to acknowledge and thank everyone who participated in the update of this plan. I know several participants and co-presenters on this call were part of that process, so thank you for that. And we're excited that the plan has been released since it was the culmination of over a year's worth of work. So as I mentioned, the recommendations from the advisory committee and input and comments that were received led to several new updates in this second version. As I mentioned, a point-of-care screening was added to the plan. And it also streamlined the text into a usable checklist tool for emergency planners at the state and local level, and a number of resources and formatting to help make the plan easier to use. So the checklist, there's a flow chart that I'll show in a moment, as well as some other resources and tools. There's also, they added a strategic objective and reworded a lot of the objectives to make them more active, and had a stronger emphasis on how to work with EMAC, and an expanded section on some legal issues and considerations. So this figure just shows how the comp plan is organized. You can see that there are strategic objectives, which really feed into the comprehensive newborn screening, and underneath those there are operational objectives along with some supporting actions. And within each of those actions there's a matrix that talks about the responsible entities who would ensure that they're implemented and maintained, and how each activity should be executed, and kind of guidelines in terms of scope of responsibility. And there are 9 strategic objectives that are listed on the screen here. A lot of them were very similar to the original plan, just with some tweaks around the language and making things clearer. But there were 2 that are highlighted at the top. The the first one was around the communication objective, and that was moved to the top just because the committee felt like that was really the most important first step to address. And then there was a new, that was a new objective that was added, and then the family number 2, the objective around families being educated around newborn screening was also moved up, just to provide that stronger emphasis on that piece of it. This flow chart is a way to kind of look at the strategic objectives along with the operational objectives, and kind of see it in terms of the process for newborn screening. And so this was just another recommendation to provide a graphic and visuals that make it easier for the planners to use when developing these contingency plans, and also communicating what should be done in case of an emergency. The plan also has very detailed checklists. This is for each strategic objective, and then the objectives and activities underneath that. And so this really follows the format of the plan, and some of the other columns that you'll see on this checklist are some resources and tips that were provided based on experiences from states and the experts on the advisory committee. So that was a new piece that was added. And then there's the responsible entities matrix as well. Some of the other additional resources that are in the plan that can be helpful when thinking about how you can apply this in your work, in your programs. There's a sample template or MOU that could be used between states or across regions. There are also background resources, from other agencies or programs that could be adapted. There are case examples, articles or features based on states that have gone through this, as well as some of the examples of the templates and resources that they have used and that they've shared with the CDC to publish in this national plan. So I just wanted to share that resource and mention that it's out there, and we hope that this updated version will be helpful to those working in newborn screening. I'll just wrap up with some reflections from the comp plan process and really going through the revision of the comp plan. And do want to state that not all of these reflections come from me, but really were some lessons learned that has been shared by some of the committee members at some of our own conference sessions and work groups when we've been disseminating this framework. The first one, is certainly that collaboration is key. I think that was one of the original emphasis of the comp plan, and really that this process and having a plan is really key to facilitating collaboration among all the agencies that will be needed to ensure that newborn screening can continue throughout the whole process during a public health emergency. And that having a national framework is helpful, but also that the state examples are really key to understanding how to do this, and that it's really important to keep sharing that knowledge and examples so we can all learn from each other. I think being able to intentionally and appropriately incorporate families in your plans and also in the process of planning, they're really will know the gaps in care and also be able to provide solutions. So just making sure that they're at the table, and also aware of the importance of newborn screening and what they need to know or who they need to reach out to if they are relocated or need to follow up with someone to find out about results or getting connected to care. And also that you can apply this contingency planning on a smaller scale. So having state plans are very helpful, but also having smaller contingency plans for everyday matters can also be helpful. One of our committee members had shared that they're one out of a two-person team in their state, so it could be a small emergency if one of them is not able to come into work, and just how some things that they can do to ensure that operations move forward, whether that's cross-training or ensuring that data and information is accessible to anyone who may need it, and that emergencies that affect operations are not always on a large scale or catastrophic events. And also, just to think of this in a comprehensive and long-term view. I mean, hopefully, you hope that emergencies or disasters aren't ongoing, or that recovery won't take too long. But certainly, thinking about how to make sure that families are able to get connected to that short and long-term follow-up. Again, if they're relocating, or just if they know who to connect to in their state, and have that be part of some of the initial education, and also for across states, just to know who you could go to find a directory of your counterpart in another state, and who to reach out to. So those are just some reflections, and wanted to share with you this national resource and framework. We're continue to disseminate and help promote this con plan and the resources within. So happy to follow up with anyone if you have questions afterwards. And with that, I will turn it back over to, or I guess turn it back over for the next presenter to be introduced. Thank you.
Thank you, Kate. That was very interesting, and I appreciated the reminders about those small everyday disasters, quote unquote, as well as things like hurricanes and floods and those large disasters that we deal with. We're going to hold questions until the end, so jot down your questions so you remember them. And I also wanted to just briefly state that when we had our short-term follow-up face-to-face meeting in May, we identified 5 topics that we really wanted to work on as a whole in short-term follow-up, and one of them was disaster planning or a con plan. So that's why we invited our great speakers today to talk with you, to kind of get the ball rolling on that, and stay tuned for more information about that as we move along. So our next speaker, I had no idea you were a Hawkeye, Gerrit, so this is a pleasure for me to introduce you. Gerrit Bakker is our next speaker. He's the Senior Director for Public Health Preparedness at the Association of State and Territorial Health Officials. Since 2010, he has had the primary responsibility for the Preparedness program, where he serves as the principal representative to federal, state, local, and non-governmental partners. While at ASTHO, he has helped direct ASTHO's response to diverse events, such as the Deepwater Horizon oil spill, domestic Ebola, and the Zika virus. Gerrit came to ASTHO in 2010 following 27 years of public health service in Colorado. And let me just speak a little bit to what he did while he was in Colorado, too, because it's also very interesting. He served as the Colorado Department of Public Health and Environment in many capacities, including directing the immunization program and the viral hepatitis program. He also served as the Deputy Director for the Emergency Preparedness and Response Division, where he was the ESF 8 lead and the State Emergency Operations Centers during emergency activations, including the 2008 Democratic National Convention. Gerrit is a graduate of the University of Iowa, the Rocky Mountain Regional Institute for Health and Environmental Leadership, the Harvard University National Preparedness Leadership Initiative, and the Naval Postgraduate School Center for Homeland Security and Defense. He also received the Roy Clear Distinguished Service Award for exceptional contributions to public health in Colorado. With that, Gerrit, I will go ahead and turn it over to you for your presentation.
Thank you very much. I appreciate the opportunity to speak on this issue, and it was a great pleasure to serve on the CONPLAN Planning Committee several years ago, and I hadn't reconnected on this issue, so I'm very happy to be able to do it today. I have had some experience with this issue both as a policymaker and as a practitioner in Colorado, so I really like being able to discuss topics of this sort where I've had some experience of that type. Today we're going to specifically talk about the EMAC system, the Emergency Management Assistance Compact, as a way to engage with other states and engage in mutual aid when you have an event take place that requires assistance from another state in doing your newborn screening. And it was mentioned some of the smaller events, and of course we normally think of EMAC with the really large catastrophic events, but I want to talk a little bit also about sort of the in-between events is something that it can be used for too. EMAC is a nationally adopted mutual aid agreement that establishes a national system to facilitate the sharing of state and local government publicly owned resources across state lines during times of emergency or disaster, as long as there is a state of emergency declared by the governor of the affected EMAC member state. So my two takeaway messages from this about EMAC are these. One, it is state-to-state mutual aid, and the other is that it does require an emergency declaration. So as far as using EMAC, you can use it to request resources, commodities, and services. If you need it, ask for it. Chances are another state will have that resource. While originally conceived as a deployment of people and of stuff, EMAC is now increasingly being used for the provision of services, such as laboratory services, and can include virtual deployments where it's not necessarily for someone to go to the impacted state, that maybe they can provide the requested expertise and service from their home location. So a little bit about the origins of EMAC. In 1992, after Hurricane Andrew, Governor Lawton Chiles of Florida wanted to find a way where states surrounding Florida could help them should they be impacted by a disaster again. So he called on Georgia, Virginia, North Carolina for help. And the response indicated was that there was a need to create a permanent legal mutual aid agreement between states. And that began what was originally conceived as the Southern Governors Association Emergency Management Assistance Compact that had 17 states. In 1995, that was broadened to include any state or U.S. territory that would like to join. And in 1996, EMAC was ratified by the U.S. Congress and signed into law. In 2004, EMAC really changed. It brought in multidisciplinary personnel who were deployed for Hurricanes Bonnie, Charlie, Floyd, all in Florida. And Craig Fugate, who later became the FEMA administrator, was the state emergency management director in Florida. And he saw the need for additional help in even more areas: fire, law enforcement, medical, EMS. And so he saw that the EMAC law was very broad and that really any resource could be requested, and used the compact to do that. A year later came Katrina. So while 39 of the 54 EMAC member states have interstate mutual aid agreements that allow for non-state personnel, many of the other states use agreements where they sign a one-time agreement. And the other thing that I want to raise with you is that the national associations such as ASTHO, NEMA, APHL, and AMCHP can be used in this situation sort of as matchmakers. So if you work through one of the national associations who happen to know that a state has a resource and you need a resource, we can help match that up ahead of the formal request for services. 2005, Hurricane and Rita were the largest deployments in mutual aid history. And EMAC has really evolved since then. Public health has more recently become a more prominent member of the EMAC community. One of the things that prompted that was the outbreak in Indiana of HIV, where EMAC was used to acquire disease intervention specialists who only spoke Spanish. So a very specialized request that EMAC was able to fill for them. The other thing is, and I'm going to talk about this in just a moment, is mission-ready packaging. Mission-ready packages are the creation of a team to do a specific task created ahead of time in the event that a particular event might occur. So just finally, who belongs to EMAC? It's all 50 states, the District of Columbia, the Commonwealth of Puerto Rico, the United States Virgin Islands, and Guam. So even though Guam, for example, may not be able to readily deploy resources, they certainly could be the recipient of them. So the EMAC process has 5 phases. I won't go into a lot of detail there, but the exact phases are less important than generally understanding that there are specific processes to follow when requesting resources through EMAC. So I mentioned mission-ready packaging. Mission-ready packaging is something that the fire service, for example, has used for a very long time. So if in the fighting of a wildfire, if a fire service requests a type 1 fire response team, they know exactly what they're getting. They know it's going to be a certain amount of trucks and a certain amount of firefighters with a particular skill. And public health has not always kept up with that ability and specificity of resources. Sometimes we even have difficulty defining what a public health nurse is or what a sanitarian is. So what the attempt and the effort towards greater mission-ready packaging is to better define, if I need help, what am I going to get when I request that help? And this could be done, as I say, in the context of newborn screening, so that specific services, particular skills and capabilities by a laboratorian in a laboratory would be better understood. This is the EMAC website. EMAC is administered through NEMA, the National Emergency Management Association. And if you want to learn more about mission-ready packaging, how to create one, they're available on the EMAC website that's on your screen right now. The other thing about mission-ready packaging, I know that's a very detailed slide, is just the fact that it has a lot of details. It tells you exactly what you're going to get, exactly how much it's going to cost, how long they can perform a service, and you get a great deal of specificity in the requests that you're making. So EMAC can be used for natural or man-made disasters, and as I said, we drew the distinction between a very small event and very large circumstances like a hurricane or something of that type. But just to give you an example, several years ago in 2008 in Colorado, we had a huge outbreak of salmonella. Over 550 cases of salmonella occurred in this outbreak, and our state laboratory was overwhelmed processing all these salmonella tests and specimens. That limited our ability to conduct newborn screening and forced us to outsource the newborn screening test for a little while to the state of Wisconsin. So while that's not a very small local incident or a big natural disaster, it's certainly the type of event that could call for some additional mutual aid. As a reminder, so EMAC itself doesn't own the resources. They're state resources deployed from one state to another state through what's called the MASS, or Mutual Aid Support System. It pulls resources available and then deploys them to a requesting state. And it allows for a real-time evaluation of inventory that is available. I'm not going to have a full understanding of the EMAC system in this quick overview, but there's a lot of training resources available on the EMAC website, and they do a lot of training, including at the EMI, which is run by FEMA. And then this is the National Program Office of EMAC through NEMA. In addition to me being a resource, NEMA is also a very good resource. And so with that, I'll conclude and allow for the next speaker.
Thank you, Gerrit. That was very, very interesting. I really appreciate that. So now you've gotten some good background into what is available. And now we'd like to hear from a couple of speakers who have lived through a natural disaster. So our first speaker for today in that regard is Dr. Hans Andersson. So Dr. Andersson is the Karen Gore Chair of Human Genetics and the Director of the Hayward Genetics Center at Tulane University Medical School, where he directs the Biochemical Genetics Laboratory. He leads a referral center for metabolic diseases in the Gulf South at Tulane Medical School. He was a clinical geneticist at Tulane in New Orleans when Katrina caused the failure of levees and resulted in the flooding of the city. New Orleans was closed to all inhabitants for over 2 months, and the Tulane Medical School had to operate out of the Baylor Medical School for 1 year. So Dr. Andersson, if you'd like to go ahead with your presentation, that would be wonderful.
And Dr. Andersson, this is Erin. If you're speaking, please press *7 to unmute yourself.
Can you hear me now?
Yes, please go ahead.
Great. So just a little emergency there to get us thinking about the topic. But anyway, thanks a lot for inviting me to speak for a few minutes. I think the last two talks have been hugely informative, but also a little bit at the higher level, and I'm going to speak to you maybe a little bit more from the ground zero sort of perspective, what's going on during, hopefully before and somewhat after those kind of things. And any of you who have come to New Orleans since Katrina know about potholes. So, they are figurative as well as literal potholes that we have here now still. Thank you very much. But anyway, I don't have control of my slides, I don't think, do I?
You should be able to press the arrow button at the bottom of your screen. If not, I'll advance for you.
Yeah, maybe I just ask you to go forward for me because it's not working for me. So next slide. So this slide is simply meant to suggest to anyone who thinks they're sort of immune to emergencies that there's plenty of opportunities to go around for things to go wrong. And, a little bit of that is geographical, but a lot of it is very local as well. So I think one of the hardest problems when I talk about this topic, when we think about this topic, is getting people to believe it's going to happen to you. probably won't to most of you, but it will happen to somebody, and buying into that notion that, yeah, it could happen to me, so I need to prepare is really an important piece of investing in this activity. Next slide, please. So this is just a graphic of Louisiana and Mississippi showing the forward progress of Katrina. And, you know, as hurricanes in our area turn counterclockwise, maybe you can see that little lake there that's called Lake Pontchartrain. All the water that was being churned counterclockwise was basically being pushed into that lake. And then as it went forward, the storm pushed that water south, and that's where New Orleans is. So the levees were broken because of the surge of that unusual amount of water. It had nothing to do with the wind or anything like that. So it was really a water event for us. Next slide, please. This is a hone in on New Orleans, if you will, and those, you can see Lake Pontchartrain at the top. That was what we were looking at before from a farther distance, but all of those darker red, green, black, and a little bit of blue, that's all water in the city, and that's the major part of Orleans Parish that was underwater at the city, that is shaped a little bit like a coffee saucer, and so when there's water there, you have to pump it out, and the amount of water was pretty extravagant. Next slide, please. So that's a picture of my med school and some of the water, so you can see maybe the automobile on the left side of that screen there in front of the Tulane Med School. And that water goes all the way north for about 5 miles at a level of, you know, anywhere between 4 and 10 feet or so out until the lakefront. The Louisiana Newborn Screening Building was in a building that is directly behind the medical school, and of course was under the same amount of water. Nobody could get into that building, and that building was actually never reopened. The newborn screening lab was reestablished in another part of the city and then moved to Baton Rouge more recently, but that building never reopened and actually was brought down. There's a nice grassy knoll there now. So next slide. You know, that's a big emergency, but as has already been alluded to, there are smaller emergencies that happen, and I think we're all sort of used to solving some of the problems that happen in our smaller emergencies. It's really this similar skill set on a different scale, potentially. So the idea here is simply to get you thinking about the fact that you're already used to doing some preparedness and solving emergencies. And so how do you think about that in terms of your own newborn screening laboratory and being able to do what has already been also alluded to, continuity of operations? That's really the whole goal here, right? Is to be able to continue doing what you're doing in spite of whatever happened for the benefit of your patients. Next slide. So there are lots of perspectives on this, or points of view about how to deal with preparedness, and I think pretty much all of them require something like a command and control organization. So a hierarchy of elements within your structure. Those are all the resources, human resources, supplies, the resources of the building, for instance, and all of those things need to be unified in some command and control structure so that you can communicate within and throughout that entire hierarchy. Redundancy is really the critical piece of each of these resources, and that is simply to say that everything you have needs to be able to be replaced because it's potentially going to disappear on you at some point. So how do you live without that particular thing? You need to have a backup for it. And that's, I think, one of the fundamental pieces of preparedness. Next slide. So these are some of the hierarchical members that you would imagine within that command and control structure. You want to have a leader, and under the redundancy principle, you want to have two leaders because one of them might go away from you. So always have co-leaders. Obviously, the other elements of whatever healthcare system or service you're providing, newborn screening laboratories, you relate to certainly reagent companies, you relate to hospitals that provide you with cards, all that sort of stuff. So you want to take stock of your hierarchy and make an understanding of how all of those pieces can talk to each other and which are the most critical. Next slide. This is just the set of principles that I'm guessing you all know, but I just throw in front of you quickly to remind you about preparedness, which occurs before an event happens. And then when an event happens, response is the immediate sort of how do you deal with that problem, recovery, and then preparedness again. And so anything you do along that way is what we call mitigation. And this is a linear arrow, but really next slide should be considered as a spiral. It should never really stop being preparedness. You should never stop being involved in your preparedness. And if you have an event, then you do the response, you evaluate it afterwards and continue to improve your preparedness. So it's not a linear thing. It's hopefully something you engage in and continue with for a long time. Next slide. So a couple of the assumptions that I think are important. First of all disasters start locally. So, before the cavalry comes over the hill, you're going to have to deal with whatever it is you have going on. And so how do you handle those local events? It's likely to take days or more before a more formalized recovery process can begin. Talked about continuity of operations. I think it's important for us all to see ourselves as the recovery plan and not rely on others to necessarily come fix our problem for us. Of course, that's a relative issue, but again, starting locally, you have to do this yourself. And redundancy is your friend at every level. You want to take stock of every resource you have and figure out how to have it backed up in some fashion or another. Next slide. It's a big topic, so I can't do much with it in 10 minutes, and so I just put up for you 3 of the publications which came out of events following Katrina, and we in Louisiana and the Southeast region got fairly exercised around emergency preparedness and did a bunch of things we thought were useful. So you can have a look at those articles if you're interested in, and to some degree, certainly the one in the middle gives a little bit of a plan. So if you feel like you haven't gotten too far down the road on this and need a guideline, that might be a very a simple way to start looking at that paper. Next slide. So you've obviously got an emergency preparedness work group, which is what I think this APHL group is, but that's really what you should do within your center, I think, and then preferably regionally or within your states, between states. Just before I finish, I think I'll just suggest that if you're not doing preparedness exercises, that would be a good goal to have, and that there are simple ways of doing preparedness between states in the way of potentially sample exchanges, card exchanges between states. You can set up an exercise for yourself that's fairly simple and basically gives you the opportunity to identify where problems will arise if you do that. You may or may not know that some years ago, Texas and Florida went through the exercise of deciding that each state would be the other's backup in the case of a catastrophic emergency. It took them 2 or 3 years to get through all of the legal wrangling and to get that done. And I think, just to end on this note, I think the legalistics of this are far less important than the informal planning that you can do with your colleagues and with your states. Don't feel like you can't make a plan that isn't legal and then be able to activate that plan either through EMAC if you need to, or through your legal folks when it actually needs to happen. It will happen quickly. But I think that a planning backup system between states, within a region, all that sort of stuff is really extremely useful and can be done without legal permission, even though it's informal and potentially non-binding. So with that, I think I'll just stop there and we can move on, take questions later on.
Thank you, Dr. Andersson. It was very interesting, and we still remember Katrina. I think we all do. So
yeah.
yeah. And you guys did a great job hosting us last year at our national meeting, and thank you for that as well.
Great, thank you.
You're welcome. So our next speaker is Dr. Sulay Rivera. She has been the Associate Director of the Puerto Rico Newborn Screening Program for the last 5 years. She is in charge of the Newborn Screening Program supervision, including both the laboratory and the follow-up section. She's been involved in research projects directed to study hereditary diseases of importance in Puerto Rico, and is also in the implementation of new protocols and methodologies at the program, including the TREC assay for SCID detection. Federal funds have been obtained under her leadership in addition to other important collaborations. Her research expertise is in the area of molecular biology and biochemistry. And Dr. Rivera-Sánchez can also add that she and her colleagues have survived a hurricane and have some lessons to share with us post-Hurricane Maria. So Dr. Rivera-Sánchez, please go ahead with your presentation.
Thanks, Carol. Thanks for the invitation. We are really glad to share with you all our experience with Hurricane Maria. As many of you know, Puerto Rico was hit by Hurricane Maria on September 20 of 2017. This was a Category 5 hurricane and literally crossed through the middle of the island, causing unprecedented damage. And many of you also know that 2 weeks earlier to Hurricane Maria, we were hit also by another hurricane, Hurricane Irma. So we were trying to recover from the consequences of Hurricane Irma when we was hit by another one and a biggest one. The consequences of Hurricane Maria to Puerto Rico were many, including complete destruction of houses and buildings, especially those in wooden structures. We had floods in different areas, completely collapse of the power system, loss of communication. And to give you an example, after the hurricane, just one radio station was operational. We had a scarcity of food, water, gasoline, destruction of roads, and isolation of some residents, family that lost everything, and many that lost their jobs in general. The poor and the vulnerable people were the most affected. According to the last estimate, approximately 3,000 persons died as a consequence of the hurricane. We were hit by the hurricane, as I mentioned, on Wednesday, September 20. We were closed the next 2 days as newborn screening program, so we reopened the next Monday, which was September 25. The Puerto Rico newborn screening program is localized in the University Pediatric Hospital, which is the pediatric hospital of the state. So this hospital is a priority for our government. So after the hurricane, what we found, our building, which is the one that are you seeing here in the presentation, it is cement-based. So our building suffered minor damages. When we came to the laboratory, we found that we have water, we have power, no stable, but we have it. We have internet, no stable, but we have it. We have one telephone line working with some occasional problems, but it was working. Because we had internet, our health information system, our electronic health information system was available. We had reduced personnel. Approximately 8 members of the staff came to work the first week after Maria. We are approximately 20, so we have approximately the half of the personnel. And no major damages were found, so we were ready to continue saving babies. Which was the impact of the hurricane in the newborn screening service? And I will try to focus on different indicators related to follow-up. The first one is that in terms of age of sample collection, when we evaluate this indicator, many hospitals were dealing with very difficult situations after the hurricane. In our case, as I mentioned, we were localized in the pediatric hospital, so we had power, we had water, but that was not the case for other hospitals. Nevertheless, the hospitals, the birthing hospital, continued taking the sample with no problem. We didn't see any effect of the event in terms of the age of sample collection. However, when we evaluate indicators like transit time or transport time from the hospital to our laboratory, we observe unexpected effect of the hurricane. For example, in this chart in which we have the percentage of a specimen received in different categories, especially if you see the red bar, which is samples that were received for approximately 7 days from a specimen collection. They were received after 7 days from a specimen collection. You can see in this red bar that after September, that number increased. Okay, so as expected, we observed consequences of the hurricane in this indicator, transport time. In terms of, and here again showing you some examples with specific hospitals. This is one of our hospitals of medium volume, and as you can see, we have this huge peak between September and October, indicating that the percentage of specimens taken in less than 48 hours after a specimen, that were received in our laboratory in 48 hours or less after a specimen collection, you can see this peak going down, indicating that this is the ideal category. We want that specimen to be received in 48 hours or less, and we are observing a decrease in the percentage of samples for this hospital, and this effect was seen in many hospitals. Here I give you another example. This is the hospital with the largest volume in Puerto Rico, and as you can see, again, between September and October, we observed a decrease in the percentage of samples received in 48 hours or less after the specimen collection. In terms of reporting our results, also as expected, we've observed an impact of the hurricane. And again, if you observe here, this is the time that takes to report out results for time-critical conditions. And if you see the red bar again in Q4, that red bar, which means that the time to report the results takes more than 10 days from birth, you can see that again, that red bar increased as a consequence of the hurricane. Not only in the previous indicators we have an effect of the hurricane, also in terms of repeats. And as I mentioned, we had many hospitals dealing with very difficult situations, and many of them without power. So especially for these two assays, galactosemia and biotinidase deficiency, which are enzymatic assays, we observed an increase in the number of repetitions necessary, and this increase and this peak was observed again in the months of September, October, just after the impact of the hurricane. The causes for this increase in repetitions probably it was because they were aged samples, also because probably these samples were not in adequate storage conditions. In terms of follow-up, that was our situation. In Puerto Rico, for that time, we had no communication in our country. We had an increase in number of repetitions for some tests. We were running with a delay because, as I mentioned, we have been observing a delay during the process, a delay in transport time, a delay in reporting our results. And in that time, we had 24 presumptive positive cases that were identified just the next weeks after Maria. What were the strategies that we used to find the families after this catastrophic event? Normally, here in our follow-up system, we use the phone, and we call the families, and that's something that I need to clarify. In Puerto Rico, our first point of contact after we have a presumptive positive is the family. It's not a pediatrician. We eventually contact the pediatrician, but our first point of contact is the family. So not having the phone lines working, and also we send letters to the family. That's another strategy that we use. But having problem with the both that normally we use, we started to use other strategies, as for example social media when it was possible. In our case, when the person that came to our building, to our program, they were able to use the internet and the social media. So they try to contact many of the cases using Facebook. We also use the help of the police. In some cases, we send the police to look for the families. We, as Kate mentioned in her talk, here when you are dealing with a catastrophic event, you need collaboration is key. So we started to send different lists of cases to the hospitals in order that they can also help us to find these families. We use volunteers from different municipalities that help us to look for families that needed to repeat samples. We use the mail office. One of the strategies that was really helpful for us was the use of text messages. Our follow-up staff send text messages during the day and the night. And for example, we had this case in which the mother received the message during the night at 2 a.m. And this mother at that time contacted our nurse because she sent the message using her personal mobile. So at that moment, our nurse had to explain to this mother what was going on, and the need that we had of repeating that sample. Also, another strategy that was really helpful for us was I was included as the associate director of the program in a WhatsApp group of pediatricians, and that was a really important contact, because I remember one case that I requested through this group the help of the pediatrician to contact another pediatrician in the south part of the island. So that's really important, to have communication with the pediatricians and to be in contact with them. Also, government offices, churches are really useful when you are dealing with major events like this one. Also, I have to mention that our follow-up supervisor had to visit 2 families with the police in order to inform them about the rural results and bring the family to evaluation. To give you a summary, in 2017, we ended with 36 confirmed cases. 40% of them approximately were identified after Maria. In terms of loss to follow-up, I show you here just the graph for 2 conditions, 2 critical conditions for 17-OH and galactosemia. And as you can see again, between September and October, we found an increase in the loss to follow-up that immediately in November we again returned back to our normality, but as expected, we had an increase in loss to follow-up. Remember, in that moment, we had no communication in our country. And I need to clarify something. And when I mention here that they were lost to follow-up, I have to mention that we contact every family and we send them also letter. When I mentioned that they were lost to follow-up, is that although they were contacted and although they received a letter, they didn't come to repeat the sample. As the previous presenters have mentioned, it is important, and this is one of our lessons learned, it is really, really important for every newborn screening program to have an emergency plan to cover both parts, to cover the laboratory and to cover the follow-up plan. In terms of the laboratory, it is ideal that you have a service contract with other laboratory prior to the emergency. In terms of the follow-up plan, you need to know what you're going to do if your follow-up system is not operational. You need to have a plan. So as a summary, lessons learned from this experience, as I mentioned, the first one is every newborn screening program needs to have a backup plan. You need to prepare for the worst, prepare for what you don't expect. You need to evaluate your facilities. You need to know what to do if you don't have water, if you don't have power, if you don't have internet, if you don't have communication with the hospitals, families, or healthcare providers. You need to consider that probably after an emergency like this one, you are going to have reduced personnel. That was our case. What to do if you have a birthing facility that is not operational. You will have problems with the delivery of samples, so that's something that you have to address. And also, you need to know what to do if your reporting system is not working. Also, it's very important to do backup constantly, important files, list of pending cases. You can lose everything during an emergency. It identifies the state agency or community group to contact who can provide help with the newborn screening service during the emergency. You need to have contact information of hospitals, neonatologists, and pediatricians. And when I mentioned that you need to have contact information, you need to have more than one number, more than one way to contact these hospitals, these health professionals, because you never know. You need to have different alternatives to see what is working at the time of the emergency. And again, revise your emergency plans, develop strategies considering different situations. You never know what you are going to found when you pass a catastrophe event like this one. And you need to discuss this plan with the staff and define roles, considering the different possible scenarios. And just to mention, commitment and resilience were key in our process to deal with this disaster here in Puerto Rico. So that's it. Thanks very much for your attention, and thanks again to all the newborn screening community that support us during this emergency. Thanks.
Thank you, Sulay. That was very good. I screenshotted your lessons learned for future reference. Thank you. Yes. Thank you to all of our speakers. We are running a little late. Erin, are we okay to go ahead and open it up for questions, or do we need to get off the line?
If anyone does have questions, we can extend a little bit longer, although if our speakers need to leave, we understand that as well. If you do have questions for any of our speakers and they have to leave, please feel free to email to me and I'll connect you with our speakers.
I'm okay.
Thank you, Erin. Thanks, Doctor. So let's go ahead then and open it up for questions for any of our 4 speakers today. Again, I would encourage you, if you have a question and you need to run, you can email that question to Erin and she'd be happy to send that question out to any of our speakers. Well, no questions?
And just as another housekeeping note, this webinar will be recorded and archived on newsteps.org. So within the next week or so, you'll be able to find it on our website. And
will that
again,
be with the slides?
Yes, you'll be able to see this whole recording with the slides as shown. And if our speakers are willing, then I'd be happy to post the slides as well.
No problem for me.
All right.
So I was just going to ask, this is Hans Andersson. Sulay, can you tell us a little bit about how's it going now? Where's the infrastructure, and how about the medical care system?
Oh, yeah. Well, things are getting better. As you may know, Puerto Rico is dealing with a really big economic problem. But in terms of the consequences after the hurricane, things are getting better. In terms of the health system, and in terms of the newborn screening, which is the part that I can talk about, in terms, for example, in terms of communication, now we are at the normality. We are again looking for the families, using calling them, and we don't have no more problems in terms of communication. In terms of infrastructure, as I mentioned here, in our building there were no major damages. For example, I have 2 hospitals that are in the recovery, birthing hospitals that are in the process of the recovery. They are not doing births right now. But they are in the recovery process. And like them, many other groups that lost their buildings and other laboratories, for example, not related to newborn screening, but other clinical laboratories lost their buildings, and they are in this process of recovery. But in general, the power was established for the majority of the population here at the island. And so we are dealing with our difficulties, as many of you also may have, for example, in terms of the health system. We have been dealing in the last years with a lack of specialists, but we have specialists that work directly with us in terms of the newborn screening program. We are really, really lucky. We have an endocrinologist, we have a geneticist, we have an hematologist, we have an immunologist. So, but we are working hard in order to deal with all these situations. But things are getting better.
Good.
And we do have one question in the chat box. Does anyone know if a state contracts with PerkinElmer what their COOP plan is?
I think that the last I heard, there's no state that is using PerkinElmer as a backup, but there are hospitals that send their samples to PerkinElmer. And the last I heard, when PerkinElmer was asked for their continuity operation plan, their emergency preparedness plan, they said they had one, but they couldn't share it. That was what came out of the con plan, if I recall. Kate, do you remember that?
This is Kate. Yeah, I do remember that vaguely, but yeah, we didn't get anything from them in terms of sharing their plan.
Good question. Does anybody else have any questions?
Actually, Mississippi may be sending all of their stuff to PerkinElmer. Because Mississippi is still not doing their own newborn screening.
I think there are a couple other states who utilize PerkinElmer for their newborn screening program as well.
Yeah, I'm not aware of that.
Yeah, this is Sulay from Puerto Rico. Right now, here in Puerto Rico, we have as backup plan, we have a contract with PerkinElmer.
Okay, good to know.
But you were sending your stuff to New York State, I thought.
No, initially after the Hurricane Maria, we started conversations with New York because at that moment we were revising what was our situation, but we never sent samples to New York. We started conversation for a possible backup service, but right now what we have in place is a contract with PerkinElmer.
Okay. Well, I think with this, we are almost a quarter of an hour over. So thank you, speakers, for your great presentations. I took a lot of notes, screenshots. And again, I would encourage all of the listeners to email Erin with any questions that you might have that she could reach out to our speakers for today. And again, thank you, and everybody have a good rest of October. Thank you again. Bye-bye.
Thank you.